Hi, it's Heidi again, and we're going to talk about where do we get the numbers to fill in our orders now that we know our vent mode and what we're going to choose for our patient and everything else about this. Where do we get the numbers? They're not quite magic, but some are. The first is tidal volume. Where do we get our tidal volumes from? Well, actually, we get them from the ARDS network. We use low tidal volume ventilation for our patients because it's been shown to improve mortality. We, sitting here, probably are breathing about 5 cc's per kilogram. ARDS net suggests 6 to 8 mLs per kilogram for tidal volume. And this is per kilogram of ideal body weight. Ideal body weight. Ideal body weight for a female is 105 pounds. Plus 5 pounds per inch over 5 feet. For a male, that just changes to 106 pounds plus 6 pounds per inch over 5 feet. So we can calculate their ideal body weight and give them 6 to 8 mLs per kilogram of ideal body weight. Well, then, what do we need for respiratory rate? And here I say, do the math. What are you looking to do? What are you looking to ventilate? If you have a patient, like a stroke patient, who comes in just with needing airway protection with their stroke, they can have an absolutely normal minute ventilation, 5 to 7 liters per minute. You get a patient, pregnant patient, cachectic, cancer patient, COPD are working hard, their minute volume's more in the 8 to 10 liter range. So you're going to calculate for your minute volume a little bit higher. But poor Susie's septic comes in, and Susie's going to need a minute volume of maybe 12 to 15 liters. And so you're going to be starting at higher rates. If you have a burn patient, all bets are off. Their minute volumes are in the 20s, very difficult to ventilate. So you have to think about who in what circumstances am I trying to ventilate. And then I just do the math. I know that if I have a patient with a 500 cc tidal volume and I'm just looking for a 6 liter minute volume, I'm going to start them on a rate of 12 to 14. That's going to get me my minute volume. I just do the math. Patients who come in and they're septic, poor Sally comes in, she's septic, she needs a minute volume of 12 liters. I'm going to start that respiratory rate at 24. So think about where you need to set your patient for what circumstances they're facing at the moment. Because if you start that septic patient on a rate of 12 or 14, you're going to be woefully behind the game with a PCO2 that's very high and a pH that's 7.08. So you need to get them what their body is demanding at that time. So that's why I say, just do the math. It's pretty simple to do the math. As far as FiO2 and PEEP, well, for FiO2, be smart. If you're just protecting an airway of a patient who had a stroke who came in breathing 21% FiO2, room air, and they're intubated just for airway protection, there's absolutely nothing wrong with their lungs, why not start that patient on 30% FiO2? Because you'll find yourself probably weaning it back down to room air sooner or later. However, if you get a patient in who is developing ARDS, has pneumonia, CHF, and they come to you on a non-rebreather, 100% non-rebreather, you're going to start them at 100%. So think about what is this person coming to me with and what do they need. You don't need to start somebody with absolutely normal lungs on 100% FiO2. Just keep them low. It's better for them. And same with PEEP. PEEP, we're going to go back to the ARDS network. There's a nomogram on the ARDSnet for PEEP. Dr. West of the West Zones will insist that we, at baseline, are keeping about 2 to 3 of PEEP at all times. And so ARDS network comes up with a PEEP nomogram that if we're at 21%, we'll start with 5 of PEEP. And as we go up to 50%, by 50% we should be on at least 8 of PEEP. 60, 70. Now we're going to come up towards 10 of PEEP, 80, 90, 100%. By the time we're on 100%, we should at least be on 12 to 15 of PEEP, and arguably more. And we'll find with patients with ARDS that we'll get PEEPs of 18, 20, even higher sometimes. So if you're on 100% FiO2, your only way to increase patients' oxygenation is by alveolar recruitment and using that PEEP to open the alveolus up. And that's exactly how we get our numbers.